About the NIMHANS session 2 for general surgery. So let me just check if I'm live properly and then we'll be talking about it. Just give me a thumbs up if you are able to see me and hear me properly. Am I audible and visible to you properly, guys? So just give me 1 second. I'll just check whether I'm live properly and then we'll be starting with today's session. Hi. So I hope I'm audible and visible to you properly, guys. Okay, so today we are here to talk about the neurosurgery part 2. Let me just wait for a couple of minutes so that students can join us. And by that time, I'll also check if I am live properly. I'm actually not able to have a look at it. Just give me 1 second. I'll just have a look at it. Okay, so I'm live. Okay, fair enough. So guys, let us move on and let us talk about today's session. So I welcome you to today's class. Fair enough. Let us begin with our. Okay, so by the time students join us, let me just introduce to what do we have on our Plus platform at this moment. So I have already launched number of courses for the upcoming AIMS. So we have this particular AIMS course for the head and neck surgery, which will be starting on the March of 11th, and the GIT is already started. I took my first session today. Then there is a kind of a course on the subspecialty which will be starting on the March of 10th, and there is a basic hardcore principles of general surgery which includes like the wound healing and all those topics that will be starting on February 28th. And I've already covered a couple of courses. If you want to have a look at it, you can definitely have a look at it on my page. The link will be in the description box. And if at all you wish to join any of the courses, do consider using my code, that is dr.pawan, drpawan-yt. Fair enough. Now let us talk about today's session. So these are the couple of MCQs which I have for you guys to take it up. So can you please tell me what's the answer to this particular question, guys? So this is the first MCQ for the day. Simpson grading system is used for the resection of. So we do use Simpson's grading system. So we use it to have a look at the resection of what? What do you think is the answer to this particular question? Right. So guys, what do you think is the answer to this particular question? Can you please tell me what's the answer to this particular question? So, Thalapalli, I just saw your kind of response. I'll just get back to you. Just give me a minute. I'll just get back to you later on. But for now, let me just complete with the MCQ session, and at the end, I will definitely answer your question. Don't worry. Now, right, glioblastoma. Okay, fair enough. So Jaya is saying it's D. What do you think, guys? So Aditya is saying it's B, ependymoma. Fair enough. Hi Maya. Hi Divya. Divya is also saying it's B. Guys, please. Whoever is online, please do answer. What's the answer to this particular question? Where do you use the Simpson's grading system after the resection of? So well guys, the answer is neither glioblastoma. The answer is not ependymoma. Now, what is the answer, guys? It is not B, it is not D. What is the answer? The answer to this particular question is C. Okay, so the answer is C, that is meningioma. So we use the Simpson's grading system. It is basically for meningioma resection. Please understand it, guys. Now this is directly from your Sebastian, and at least Sebastian you should be thorough with if at all you are trying to prepare for the NIMHANS examination. Fair enough. So this is a Simpson's grading system. What exactly it does? It basically tells you what is the chances of recurrence if at all you have done a resection. Now, if you are able to kind of completely resect the kind of a meningioma, along with its dural attachment, and at the same time the abnormal bone which is underlying it. If you are able to kind of remove all of these things, the chances of recurrence are very less. That is kind of it is only 10% chance of recurrence, and this is grade 1. If at all you are able to just completely remove kind of the meningioma, but you just cauterize the dural attachment, you're not able to completely remove the dural attachment. Now in this particular case, you just cauterize it, and with this the chances of recurrence are around 15%. Now the grade 3 is there is a complete resection without the dural attachment. So here you do not remove anything to the dural attachment. So the chances of recurrence are around 30%. If there is an incomplete resection, that is grade 4, and the chances of recurrence are very high, close to 85%. And grade 5 is basically you have just taken up a biopsy. So here the chances of recurrence are around 100%. Fair enough. So please understand, Simpson's grading is basically used for meningioma and meningiomal resection. It is basically used for that. Now, good to have all of you guys. Now let us have a look at another question for meningioma. Okay, so which of the following statements about meningioma is false? So the statements are: it is more common in females, about 1% of the lesions have a malignant feature on histopathology, and asymptomatic patients are observed, and the prevalence in the children is same as that in the adults. So what do you think is the answer to this particular question, guys? So which of these statements is false regarding meningioma? What do you think is the answer? Can you please tell me what is the answer to this particular question? Anybody guys? So Maya, Avril, what is the answer? So Aditya is saying it is D. Okay. Anybody else guys? So Deepthi is saying it's B. Evan is saying it's D. Okay, so many people are up for D, right? So Deepthi is saying B. Well guys, yes, you're absolutely correct. The answer is in fact D. The prevalence in children is much lesser as compared to the adults. Okay, now let us examine all of these statements. So the first statement says that it is more common in females. Yes, it is more common in females. The ratio of male is to female is 1:2. Okay, so it is twice common in females as compared to that in males. Okay, so yes, the ratio is 1:2. Now about 1% of the lesions can have malignant features. So basically the kind of book says less than 1%. So about 1% of the kind of meningiomas may have a malignant changes with it. Fair enough. Asymptomatic patients are observed. Yes, no doubt. So please understand the criteria of the resection. It is not actually the size of the meningioma. If at all, even if it is a small meningioma, but it is causing some neurological deficit or it is causing some symptom in the patient, you have to operate on it. And even if reasonably a larger size meningioma, but it is not causing any of the symptoms in the patient, you can observe. Okay, so asymptomatic patients are observed, and the symptomatic patients are the ones who are kind of operated. Now, the prevalence in the children is the same as the adults. That is absolutely false. It is not a true statement. So the meningioma is much more common in adults as compared to the children. Now, another thing which you need to understand is if at all you find meningioma in the children, if at all it is present, then you have to rule out neurofibromatosis type 1. Okay, so this is another MCQ which can be asked to you. So meningioma in children, it is associated with neurofibromatosis type 1. Okay guys, fair enough. Now let us move on and let's talk about the another question. So the next question is surgical resection of a vestibular schwannoma. So not just any schwannoma, vestibular schwannoma. It is always recommended if the size of the tumor is more than. So when will you go for a resection of a vestibular schwannoma? If the size of the tumor is more than 1, more than 2, more than 2.5 or more than 3. What is the answer to this particular question? Now Deepthi is saying it is C, it is D, fair enough. A1 is saying it's C, 2.5 centimeters. Anybody else guys? So Thalapalli is saying it is C. So Thalapalli, just wait, I'll definitely get back to your answer, don't worry. I'll your question which you have asked me. Bala is saying it's C, Raghu is saying it's C. Okay guys, what's the answer to this particular question? Well, the answer to this particular question is in fact D. Okay, so if at all the size of a vestibular schwannoma is more than 3 centimeters, then only you consider to kind of do the resection. Now why is it so? Why do you consider resection only when the size is more than 3 centimeters? Because if the size is less than 3 centimeters and if you try to go for a resection, there is a lot of comorbidities which is associated with the resection of a vestibular schwannoma. Okay, so there is a lot of comorbidities. Now what is the comorbidity which is associated if at all you do the resection of vestibular schwannoma? Patient can suffer from hearing loss. Okay, and also there is a facial nerve palsy which can occur in this particular patient. So facial nerve palsy can occur. So if at all the size of the tumor is basically less than 3 centimeters, you usually don't prefer to operate. You usually go for a conservative observation kind of a treatment. And nowadays we have come up with a stereotactic surgery. Okay, so stereotactic resection is basically kind of in the vogue. So stereotactic surgeries are advised, or they are kind of preferred if at all the size of the tumor is less than 3 centimeters. The outcome which we have got out of it is encouraging. But if at all the size is more than 3 centimeters, you definitely have to go for a resection. That is a direct line from Sebastian. You have to remember this. Now, another important thing about schwannoma is, so schwannoma can either occur in the brain parenchyma. Okay, so it can occur in the brain parenchyma, or it can be a vestibular schwannoma. So usually when it is occurring in the brain parenchyma, it usually manifests in less than 30 years of age with seizures and headache and all those things. But vestibular schwannoma, if at all there is a vestibular schwannoma, it usually presents after 30 years of age. Okay, so vestibular schwannoma, it usually presents after 30 years of age, and it presents, the presenting feature of this is a tinnitus and all those things. But if at all there is a brain parenchyma, in that there is a schwannoma, then it usually presents before 30 years of age. Okay, so this is all about the schwannoma which I wish to convey to you. Now let us talk about the next question. Which of the following statement is false regarding the brain abscess? So we have these 4 statements regarding the brain abscess. Which of these is false? Now 25% of the children with the brain abscess have a congenital anomalies of the heart. Hematogenous spread of the infection is the most common route of spread of brain abscess. CT scan presents with a ring enhancing lesion. Clinical signs of the infection can be manifested in many of these patients. What do you think is the answer, guys? So can I just know what is the answer to this particular question, guys? Can you please tell me what is the answer to this particular question? So Dhananjay is saying it is B. Okay. Deepthi is saying it's A. Thalapalli is saying it is A. Okay, guys, what is the answer? Please answer, whoever is online. I can see 15 students are online and I want each one of you to answer, guys. Please do put up what's the answer. So Aditya is saying it's B, and most of the people are saying that it is A. Okay. Jaya is saying it's T. Well, guys, the answer to this question is in fact B. So good. Really good, Dhananjay and Aditya, very good. The answer is in fact B, guys. Okay, so what's the answer? Answer is B. Hematogenous spread of the infection is not the route of spread of the brain abscess. Now let us have a look about the brain abscess. Okay, so let us have a look about the brain abscess. Okay, now brain abscess, is it more common in kind of children, or it is more common in the adults? So it is more common in children and young adults. Okay, so children and young adults, it is most common. Okay, right. Now what will happen? How does the brain abscess occurs? How is the abscess actually occurring in this particular patient? So the abscess is basically, there is a direct spread. Okay, so what is happening over here? There is a direct spread of the kind of a infection from the paranasal sinuses or the middle ear, or directly from the bone. Okay, so we have the paranasal sinuses and the middle ear. So direct spread of infection from these particular places, this is the most common kind of route of spread, or the most common cause of the brain abscess. In close to 50% of the patients, it is occurring because of this. Fair enough. So this is important. Now another important thing is, yeah, it is more common in the children. That is fine. How it is spread, now we go on. Now we know. What about the clinical features? How will the patient of a brain abscess present to you? So patients will present to you with signs of kind of compression symptoms. Okay, so like a space occupying lesion, like the kind of rapidly expanding space occupying lesion, it will basically compress the surrounding parenchyma, and that is how the patients will develop signs and symptoms. Okay, so the features of compression of the surrounding brain parenchyma, this is how the patient will present to you, right? The patient may come to you with a headache, with a seizures, convulsion, whatever, depending on what part of the brain abscess is present. Now CT scan definitely shows a ring enhancing lesion, but this is just one of the kind of a things which presents with the ring enhancing lesion. There are many other things which can present as a ring enhancing lesion, so just go and have a look at the DDs of a ring enhancing lesion. This is important for you guys. Okay, there are lots and lots of diseases or conditions which present as a ring enhancing lesion of the brain. Now, lastly, the clinical signs of the infection are present. So please understand, this is important. Around 60% of the patients do have the clinical signs of the infection. It means that when you examine the vitals of the patients and other things, you know that there is some or the other infective focus which is present in the patient, and this is present in around 60% of the patients. Now let us talk about the organism. So what is the kind of organism which is usually present in the brain abscess? So it is a polymicrobial, okay? It is not just a toxoplasma is one of the DDs, that is fine. But yeah, how is the what are the organisms which lead to the brain abscess? So it is mainly polymicrobial, okay? So it is not just anaerobic or aerobic. It is kind of a gram positive, gram negative, and even the anaerobic, and even the fungi can cause the brain abscess. So it is usually polymicrobial. Sometimes even the parasites can lead to a brain abscess. Fair enough. So it is, we cannot point out any one particular thing. The best answer is it is polymicrobial. Fair enough. Now, the last question for the day is about mycotic aneurysm. Okay, so let us have a look at it. Which of the following statements about the mycotic aneurysm is the false statement? Okay, so again, what I'm trying to ask you is which of these particular statements is false? Okay, so what is the answer to this particular question, guys? So the options are: it is common in patients who suffer from subacute bacterial endocarditis. Okay, so if at all there is a subacute bacterial endocarditis, does it increases the chance of mycotic aneurysm? Okay. Clipping of the aneurysm is the preferred treatment option if they present early with hemorrhage. So if at all there is an aneurysm which is bleeding, clipping is the preferred treatment. Okay. The most commonly involves the distal circulation basically, and the cerebral vascular blood. So this can be distal circulation. Okay. So this should be distal circulation. Okay, right. So is the distal circulation more commonly involved and the cerebral vascular blood more commonly involved, or the main, that is the circle of Willis, the central vessels, this is the more commonly involved? What is involved? Just let me know. Now, the presence of the intracerebral hematoma may be an indication for an immediate craniotomy. So if at all you have a hematoma, you have to go for an immediate craniotomy. So what is the answer to this particular question, guys? Tell me what's the answer. So what I'm looking for, which of these is a false statement as far as the mycotic aneurysm is concerned? Okay, so what is the answer to this particular question, guys? Please answer. So I can see I have 14 students online at this moment. I want you guys to answer. What is the answer to this particular question, guys? So Aditya is saying it's B, Deepthi is saying it's B. Fair enough. Anybody else? Raghu is saying it's B. Okay. Anybody else, guys? So Dhananjay, what do you think? What's the answer? Okay, I'm just waiting for your responses, guys. Please do answer so that I can move on. Okay, so Jaya says it's D, and Dilima says it's A, Dhananjay says it's B. Fair enough, guys. The answer to this particular question is in fact B. Good. Many of you have answered it correctly. Very good, guys. So very good. Aditya, Deepthi, Raghu, Dhananjay. Yeah, very good. Right. So let's talk about the mycotic aneurysm. So what is a mycotic aneurysm? You must have heard about it many times, right? So mycotic aneurysm, it is an aneurysm which is occurring. So this is basically an infective aneurysm. Now please don't consider because it is an mycotic, it doesn't mean that it is caused by fungus, okay? It can be caused by any infection. So it is not just caused by fungus. This is a kind of a myth which the students have. Forget about it. Any infective aneurysm, that is a mycotic aneurysm. Now what happens is, in many patients, if at all you have a kind of a congenital anomalies of the heart, let's say a tetralogy of Fallot or something, the bacterial and subacute bacterial endocarditis. So if there is a bacterial endocarditis or a tracheal fistula or any kind of a congenital anomaly of the heart, which is a high flow lesion, what can happen? These vegetations can embolize and it can go to the brain, and in the brain they can cause a mycotic aneurysm. Mycotic aneurysm. So if at all they are going to the brain and leading to the mycotic aneurysm, what do you think? The bigger the central vessels will be involved or the distal vessels will be involved? Definitely the distal vessels will be involved. Okay, so distal vessels are involved. Now do you think it will be a solitary abscess or like solitary aneurysm, or there can be multiple aneurysms? Because it is kind of embolizing from the heart to the brain, definitely it will be a multiple. Okay, so they will be multiple. Usually they are multiple. Fair enough. And how do they present to you? So what happens basically, whatever the infective focus, like the bacteria, whatever it is, it basically erodes through the vessel wall and it leads to the hemorrhage. Okay, so mycotic aneurysm usually presents as a hemorrhage. And if at all there is a hemorrhage which is present in the mycotic aneurysm, you have to do an craniotomy. You have to do a craniotomy, you have to go to that particular site. So once you go to that particular site and if you try to treat the mycotic aneurysm, so can you go for a clipping? Okay, so we have already answered that clipping cannot be done. Fair enough. But if I ask you why clipping is not preferable, clipping, why not? Okay, so if I just ask you why not, why you should not go for a clipping? Because, see, understand, what is clipping basically? So you have this kind of a neck of a aneurysm and you basically go and you apply a clip at this particular neck. Now what is happening in this mycotic aneurysm, if at all it is an acute, okay, so if it is an acute mycotic aneurysm, what will happen? The fibrous tissue will not be developed properly, and if at all the fibrous tissue is not developed properly, what will happen? You will not be able to apply the clip. So what you have to do, if at all you do in craniotomy, you have to do something, right? So what you basically do is, whatever the part of the bleeding vessel is there, you have to basically just ligate it, okay? And you have to be prepared. If at all this particular vessel is supplying some part of the brain which is very, very vital, and you cannot just ligate it, you have to be prepared to go for a bypass of that particular thing. So you have to ligate it and you have to do a bypass. That is, you have to do. But this doesn't go that well whenever it is planned. It doesn't go as planned. So it is very easier said than done. The bypass procedure is usually not that easy to be done. So, but what you have to do, if at all you are operating in a patient who is suffering from acute mycotic aneurysm, you have to go inside and you have to ligate that bleeding vessel. Okay, understand this thing. But if at all you have some kind of a patient with a mycotic aneurysm who is presenting to you with late. So if you have a patient who is presenting to you late with a mycotic aneurysm, in this particular patient, the fibrosis and the fibrous tissue would be developed, and in the late mycotic aneurysms, you can go for clipping. Okay, you can go for clipping. Please understand this. You can go for clipping in the late mycotic aneurysm, but in the acute phase, clipping is not possible. In the late phase, what is the problem do you face? The problem which you face is, it is involving the distal circulation. Okay, so that is the problem which you face in finding that particular aneurysm, and because it is a distal circulation, it is a very, very small vessels. So that is a problem which you face with a late presentation. Fair enough. Now, another important thing is the baryoaneurysm. You obviously know that the baryoaneurysm is the one which involves the central vessels, and mycotic aneurysm is the one which involves the peripheral vessels. So this is the basic difference between mycotic and the baryoaneurysm. Fair enough, guys. So yeah, I think I've covered this. So thank you so much for joining with me. If you have any doubts, please do put up. Now, before I proceed forward, I just want you guys to just stay for a couple of minutes. I'll be more than happy to have a word with you. And yes, another thing, Thalapalli basically asked me at the beginning of the session is, if at all you are getting a good DNB in the surgery, should you go with it or should you wait? So please understand one thing, it depends on lots and lots of factors. If at all you are kind of a intern who has studied along with the internship and you are getting a DNB surgery, and this is one kind of scenario, and maybe if you are a kind of in a drop year and now you're getting a DNB surgery, this is the one factor which is to be considered. So basically the factor which is to be considered is, are you willing to sit back and study with the same enthusiasm, with the same zeal? Another factor which you need to be considered is, whatever the kind of place which you're getting, okay, so if at all you're getting a DNB surgery, so I think you mentioned that you're getting at a good place. Now how do you define a good place? So there's nothing as in which is called as a good place, at least in the surgical branches. What exactly is important is who becomes your guide. That is something which is very, very important, because in many of the places what happens, even the rotation amongst the units is not there, and who becomes your guides, that is something which is very, very important. It is important at least in the surgical branches. So rather than the place, what you should be looking at is the department, and to be specific, the guide. Like the probability of you landing up with that particular guide, is it good? Is he good? Is he supportive? Is he not supportive? This is one thing which you have to look for. Another thing which you might consider is your basically aspirations. So if at all you will be happy enough to proceed with, see, understand, there's nothing like if you do a DNB surgery, you will not reach up a good heights. It's nothing like that. If you just look at the particular last thing, urology, which is one of the most kind of sought for MCH branches in the surgical specialty, the recent PGI exam, the first ranker of the PGI, he is a DNB candidate. So it's really nothing like you have doing a DNB or you are doing a MS. It is ultimately, it is you. Fair enough. So this is one point. So you have to look at aspirations. Like, will you be? Is it something like you want to do it from this particular institute only? Do you have that in your mind, or you are kind of a person who wants to just take it up and then whatever you kind of learn from that particular place, and then you will build yourself up by doing one or the other thing. The only drawback of doing surgery or any other branch from kind of an average institute and doing it from a really really great institute, what is the basic difference is, ultimately, if at all you are willing to work on yourself, ultimately the kind of a knowledge which you will gain after 10 years of age, after 10 years, or the kind of skills which you will acquire, they will be pretty much the same. The basic difference will be your outlook of looking towards the world, your circle, your professional circle, and yeah, basically your outlook and your professional circle. Because if you are at a better place, you are more likely to be with a more like-minded people. Okay, so that is the basic difference which you have. So Thalapali, I really don't know what exactly is your condition, but these are the factors which you should consider. So according to me, there is nothing like you should not take DNB or you should take MS only. If at all you are getting at a place where the cutting is good and your guide is good, he is supportive enough. So that is something which you have to look forward, and then you have to move ahead. Whatever the lackings might be there in that particular program, so every college has its pluses and minuses, just have a note of it and then decide to work over it as and when you get an opportunity. So this is the best answer which I can give whatever you ask me. Okay, so if you have any other specific doubt, please do ask me. I'll be more than happy to answer. Okay, right. Now lastly, I just want you to guys to just stay with me and just have a word about the Plus platform. So we are trying our best to provide the value added information, and I hope these YouTube sessions are helping you out. Now just imagine if these YouTube sessions are helping you out, definitely we are doing much more on our Plus platform. So I just request you, I urge you to just come on the Plus platform and have a look at it. And if at all you feel that whatever we are doing in there, it might support your preparation, it might help you to get along the NEET PG, the AIMS, the PGI, the NIMHANS, whatever, please try it out. Because it is comparatively new, the students are not that much aware of it, but we are giving our best, and you can also have a look at the kind of the feedback which we have got from the students. So I'll just request you, just give me a couple of minutes, just go down on the link below, just go to my page, just have a look at whatever the courses which I have launched, and just have a look at the dedication sections, whatever the students have commented according to the coaching, according to whatever the classes which we have conducted, according to the platform, whatever they have done, just have a look at it. Just give me a couple of minutes, just go on the link and just have a look at it. And please do follow me there so that you will get all the notifications of kind of the free classes. We also conduct free classes on our app, so these are called as special classes, so you'll get a notification regarding that also. And if at all you feel that we are doing something to kind of help you out and you might get benefited out of it, and if at all you decide to kind of join us along the journey, so these are the plans which are available at this moment. The one year plan will be available to you in 22.5K. And in this, what you will get unlimited access to all the videos by all the educators at the same time. So there are multiple courses on the platform. Just go there and have a look at it. So you will get unlimited access to all the courses. You will get unlimited access to the structured notes, the Q bank, the test series, and towards the end of the